It's 3 o'clock. There's lots of people on. We're super pumped. Happy February. Happy Women's Her Heart Matters Heart Health Month.
Nice.
Wear red or pink on February 13th. That's kind of what we're talking about. Heart issues cause 25 to 30% of our strokes, kind of come from a cardioembolic source. So although obviously the brain is the most important organ in the body, we have to tip our hats and respect the heart. Welcome if this is your first time here. I'm Ruth Whalen. I'm clinical nurse specialist of stroke services in Saskatoon, but work a lot kind of across the province with stroke centers and just systems work. And usually I have Dr. Brett Graham with me, but he is away this week. And so our producer, Ashley, is stepping in as co-host.
Hi.
So thank you, Ashley. And I'm going to start with our land acknowledgement, and then we will jump in. Okay, so we meet today here on a virtual platform, and I want to acknowledge the Indigenous peoples of all the lands that we are on today and take a moment to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and reaffirm our relationships with each other. And again, the purpose of Coffee and Cases is to present some interesting topics having to do with stroke throughout the continuum of care, bring any of the new latest kind of research or best practices that are coming down the pipes, and have kind of a back and forth. So if there is a topic or an opinion you have about what we're chatting about or something you want to learn more about, please, you can send it our way. And the chat is active, ready, set to chat. Ashley's going to monitor that as we go.
Yeah.
So it's kind of a cool Coffee and Cases today.
Mm-hmm.
We are honoring our recreational therapist because on top of it being Heart Month, it is also Rec Therapy Month, right? That's right? Yes, it is, Queens. Okay. So Crystal and Shailene are here and they are going to, do you have a question, Ashley?
Oh no, I meant to do a party thing, but it just did the hand. Sorry.
Okay. So Crystal Toth and Shailene Leibel-Smith are here to chat about their topic they've chosen is Beyond Survival, Connecting Through Recreational Therapy. And let me tell you just a little bit about them. Shailene is a rec therapist with the Saskatchewan Health Authority in Saskatoon, both on the inpatient rehabilitation unit and rehabilitation outpatient specialized services, or if you hear us talk about ROSS, that's Rehab Outpatient Specialized Services at Saskatoon City Hospital. With more than 25 years of experience across the prairies in peds and adult settings, including child life, inpatient substance misuse services, and community transitions, her practice centers on meaningful participation, emotional regulation, and supporting confident return to community life. Outside of work, Shailene is, hey, this is neat. She is the head coach of Saskatoon's first Power Chair soccer team, championing inclusive sports for athletes of all ages. She feels most grounded outdoors and treasures life on her acreage with her human family members, adopted goats, Benny and Clyde, a flock of well-named lane hens, and a small crew of cats. Whether coaching, gardening, or reading under a favorite tree, she believes deeply in the restorative power of connection, nature, and play. Thank you for being here, Shailene, to present. And then Crystal is a CTRS designated recreational therapy working in inpatient physical medicine and neurorehabilitation at Saskatoon City Hospital. With previous experiences in acute mental health, She's a U of R graduate, and her practice focuses on supporting participation, identity, and quality of life through meaningful recreation and connection. Outside of work, Crystal enjoys Saskatoon's cultural and community activities with her spouse and daughter, dancing in the kitchen while cooking or baking, and discussing the mental health benefits of enjoying a high quality cup of coffee. Cheer! Oh, wait.
If I can.
Cheers to that. That's right. Okay, ladies, without further ado, please take it away. And again, actively participate in the chat we are watching and can pass on any questions everybody else might have.
All right, so bear with me. I'm going to try to share and get this into the right. Okay. All right, everyone can see okay, can hear us okay, hopefully?
Yeah.
Excellent. Okay. So yeah, welcome everybody. Thank you guys for having both Shailene and I. It is Recreation Therapy Month, and one of recreation therapists' favorite hobbies is talking about recreation therapy, especially during Recreation Therapy Month. So we appreciate you giving this opportunity. So our presentation today, what we actually, Shailene and I went back and forth as to exactly what it is that we wanted to be able to discuss, because we wanted to make sure that we took this opportunity to speak to people provincially and those who work in multiple different areas with individuals who have experienced strokes, the opportunity to be able to really understand and learn what it is recreation therapy is and really what the impact that it has. We ended up deciding that let's just go to the basics, that this is coffee and cases, that we thought we'd actually do a case study on an individual that gave us permission to utilize their story to show the benefits of what occurred from inpatient to community and the opportunity of having an inpatient recreation therapist and an outpatient recreation therapist and how it was able to support that individual in their care. I know you already did a land acknowledgement, but we wanted to ensure that we did one as well too, because we do feel that it is something that's important to us. So we do wish to begin by acknowledging that this presentation is being shared virtually across Saskatchewan. We recognize that we are each joining from lands that are the traditional territories of First Nations and Métis peoples, and that this province is covered by Treaties 2, 4, 5, 6, 8, and 10, as well as the homeland of the Métis Nation. As healthcare providers, we recognize that our work is connected to the calls of action of the Truth and Reconciliation Commission, particularly those that call on health systems to address inequities, provide culturally safe care, and support healing that extends beyond hospital walls. In stroke rehabilitation, healing is not only about physical recovery, but about restoring identity, purpose, and connection to community. Today's case invites us to reflect on how our roles can support dignity, participation, and belonging through the continuum of care. With respect and humility, we commit to ongoing learning and reflection and to taking action in our roles as clinicians to create care environments where Indigenous patients, families, and communities feel seen, respected, and supported through their healing journeys. So, why is this not working all of a sudden? No. Oh my gosh, you guys. There we go. Okay, now we're good. Okay, so what you're going to see throughout this presentation is you are going to see a smattering of photos that we have taken over the years of various different either projects that patients have worked on or activities that patients have participated on. We might touch on a few of them, but they're also just kind of there for a bit of a reprieve from all the words and all the talking as well, because we're recreation therapists, so we're going to present as recreation therapists. So one of the key things is that within the healthcare system, we often focus on the medical stabilization and on impairment reduction. However, with current population trends leaning towards a more medically complex and socially exciting, and we stole that term from one of our social workers here, individuals, I am sure that every single one of you have seen what we see, where the idea of medical stability alone does not determine a person's readiness for reintegration into community. So today we want to be able to show how a participation level, assessment, and intervention directly impact discharge success and that community reintegration for individuals. So our case study, so we have a 62-year-old male who experienced a right subcortical stroke. At the time of admission, cognition was oriented, but with mild delayed recall with cueing. With mobility, they were at wheelchair level upon admission to inpatient, and at discharge, they discharged with a manual wheelchair, but beginning to use a two-wheel walker indoors. Currently, they are with use of a cane independently. During their time of admission with inpatient, they were newly diagnosed with type 2 diabetes as well as hypertension. Previously, they lived alone and were self-employed, working out of their home. Emotionally, here within the hospital with inpatient, they were quite tearful, a lot of sense of overwhelm. They dealt a lot with challenges with a sense of adjustment, going from being somebody who was a very highly independent individual to someone who was needing to depend on a lot of individuals and services. Their main referral trigger to inpatient and to myself was mostly their low mood and their ability to engage within other therapies as well too. One of the biggest issues for this individual is sometimes they were so overwhelmed and dealing with a lot of grief with that transition that they would not want to get out of bed while here in hospital. Their main referral trigger for outpatient was to continue that support for social reintegration as well as to reduce isolation risks, as this individual had noted that they did self-isolate prior and they actually had a fear to return to that self-isolating behavior. So on paper, this kind of patient, they may seem ready on paper for discharge. Physically, they've met their goals. Functionally, they're ready to go. But there's some key aspects on here where there is potential for them to struggle upon discharge. So nothing here specifically flags anything about cognitive impairment, but there are several factors that elevate that reintegration risk that we would be potentially concerned about. So one quote from this individual from their initial psychosocial assessment, they stated that I don't know if I want to be around if I do not improve. This individual, again, I really, really want to highlight, was somebody who their independence was a massive part of their sense of identity. They were somebody who felt that they needed to do everything on their own at all times. And so to go from being highly independent to the point where they just self-isolated to suddenly having the need to depend on nursing, PT, OT, SLP, social work, us as well, and the potential for them to be going home with that need as well was something that was quite difficult for them to be able to deal with. Some pictures. A car that a patient of mine made for his granddaughter and one of our therapy dogs. Sorry, random pictures. All right, so my initial assessment, a couple of the things that we sort of looked at was that emotional regulation under functional demand. So one of the things for this individual was that they had a very difficult time regulating themselves emotionally when they were faced with any sort of reminder of any sort of functional decline that they have had. They had a very difficult time being able to process that and work through that. One of the other things too was readiness for participation beyond the unit. So that idea of participating in anything outside of the hospital, this idea that I can't do it, therefore I won't do it. Also identity disruption, that fear of dependence. So again, going back to that person being a highly, highly independent, strong-willed individual, and that sense of identity was completely disrupted, which affected a lot of their work. Early health behavior integration risks as well too. This was somebody who is a smoker as well, somebody who liked to push themselves past the point of exhaustion, work many, many, many hours, and so a lot of risk for them to be able to continue to push themselves past their point of what was considered healthy for them. And then as well, that community tolerance. So looking again at that fatigue, pacing, mostly though confidence. So looking at that idea of what is my purpose within the community when I no longer look like the way I did, or I'm unable to do what I used to do. More pictures. We do want to include some of these pictures because not only they're fun, they're colorful, it's exciting to see the things that we do. But when we see these things, we're seeing a lot of wins for the individuals that we're working with. So in the case of some of these patients, these aren't necessarily things that I did with this patient, but a lot of times we like to explore a variety of activities. So with the individual who's painting, that was a fantastic session where we got to actually work with, it was a multi-generational session. So they had the patient and their grandchild who got to participate in something which was something very socially important to them. For the other individual, archery was something that was, again, something that they had actively been part of. Their stroke had affected their right hand dominant, and they were unable to use their right hand. And so we kind of, between their spouse and myself, figured out ways for them to continue to participate. anyways, I digress. So looking after assessment, what sort of intervention we were looking at with inpatient. We looked at graded participation exposure on the unit. So again, looking at a variety of different activities, taking our time with it, trying not to push too much too quickly. Again, this is somebody who didn't really socialize a lot previously, but there was a want for socialization. And so it was trying to slowly work into that. How do we connect to each other? How are we able to do this with where we're at? A lot of emotional regulation coaching during those frustration periods. How do we be able to support ourselves? What are some techniques and stuff that we can use? Looking at even certain recreation activities to be able to use as a tool for some of those emotional dysregulation moments. Looking also at early pacing and fatigue awareness, just again, because both within their other therapies, but also with the chance that when they return home, that pacing and potential fatigue would be an issue. So trying to start to discuss that. Also looking at health behavior conversations that we embedded into some routine as part of it. And then the big one was that discharge risk flagging for outpatient and then be able to do the handoff with planning. One of the biggest things, though, that we really, both myself and the patient, really tried to focus on wasn't the idea of regaining independence. It was more about preparedness. So we were already thinking, as negative as it may sound, what will fail first at home? And so we wanted to prepare ourselves for that. So again, setting up for success. More pictures. One of the things too, and Shailene can speak to this a little bit later. So this individual cooking was something that was part of their outpatient everyday part. So we want to make sure we kind of included that as well too. Anyways, I go on. Oh, you're freezing again. Sorry, guys. Come on. Sorry. There we go. Okay. So that transition. So this is one of the things about that I personally really appreciate about the rehab unit here in Saskatchewan City Hospital is that we not only have ourselves as inpatient recreation therapists, but we do have an outpatient recreation therapist. There's many areas within SHA that does not have that. And actually, when it comes to rehab in general, even whether it's in Regina and other places, they also do not have that. And so I feel we're very fortunate, but at the same time too, it's a big lack in service because having that ability to bridge from inpatient to community, which we'll be able to kind of show why it's important here. But anyway, so this idea though that with the transition that we're bridging into community, we're not just dropping the patient. It's not discharge, see you, bye. So a couple of key things here was identifying that readiness for community exposure. One of the things that this individual continued to repeat to me towards as we got closer to discharge was that they did not want to return to those isolating behaviors that they had before. There was a lot of fear actually about that. They started to realize what it was like to be able to connect with others, to be able to participate. And so they did not want to return to those past habits and routines. And so making sure that that readiness was identified was a big part. Shared participation risks with the outpatient rec therapist. So there was a lot of conversation as we were getting closer to discharge about what some of those potential risk factors and barriers would be to participation. Again, one of the lovely things is that warm handoff from myself to Shailene. And so Shailene would be able to attend a couple of our sessions while inpatient. So that way that rapport and that therapeutic relationship was able to start to develop at a sooner stage. So it wasn't just bye and then hi right away. And then also that continuity of goals across settings, big thing again. So that way we're continuing to work on something from all the way here, from inpatient, transitioning, and then all the way out. So it's not just like a start, stop thing. Continuity matters. We all know this. Without it, that's where we start to see that those gains and stuff reduce very quickly. And so being able to do that is quite important. Pictures. That's you.
So that brings us to myself, the outpatient recreation therapist. And so just to explain, that warm handoff is really important for our services. We're finding that most of our folks, as they go back into community, it's that lack of confidence. They were independent in the community before, and now they sort of feel like they're going into this new community as opposed to their old community, and they just feel lost. And so even having that supported transition, and so supported participation helps when they meet other services. So at this point, we do a reassessment based on that transition. Again, still looking at role and identity disruption that continues, but it's not captured very well on any of the cognitive screening that we do. And also, once real life is here, there's other hidden risks that surface quickly. When we were talking about emotional dysregulation, want to stress that the client really said that this is a lifeline to make sure that they did not return to those isolating behaviors. They were very well aware of their mental health needs and where their risks were. This was an individual who had chosen not to accept psychological and psychiatric support or medications. That was a choice that they were making. And so they were looking to make other behavioral choices that would continue to support their positive mental health. And so there certainly was reduced leisure self-efficacy. Part of that was also that they really didn't know what they enjoyed. They did have a great opportunity as an inpatient to explore many different activities. And there were times where the patient would participate and say, I had a really great time doing this. I'm never going to do this again. And we talk about that as being a win. That's not a loss at all. That's data. That is information that the client gets to walk away with and know. And then also still look at what the high risk participation barriers are. They would joke that they don't really like people. And so how does that person go into groups of others and socialize? Really what it came down to was their lack of self-confidence that others would like them and being okay with how do I present myself in these groups.
Pictures.
So here are some pictures, some of which actually were done still as inpatients, but just to give you an idea of the things that people have abilities to explore with us. We want to support people out in the community doing what they want to do, and we want to show them how they can do that. And so how can they do it with family members? And so we will often involve their supports in the interventions that we're doing, both down the street by the river. We have a great location over here, as you can see, or down the city in, what is that, Silverwood Golf Course. So we have some great accessibility. And then if you go here to this winter, we had a great opportunity. We can bring a outdoor snow sport club into the facility to expose our patients to the opportunity to downhill ski. Here's the equipment. They get to practice transferring, learning how to do that, and then we're able to support them out in the community. And for the first time last year, that included Optimist Hill. So for many of our city folks who use Access Transit, going out to Table Mountain isn't an option where this club would normally operate. So we now have the opportunity to do that within the city. And so then back to our patient, we want to continue, but graded community exposure. So we're looking at supporting. That meant that I planned with the patient where he wanted to go, what programs he wanted to explore. We set up to meet at those locations. And so the patient was responsible to set up transportation. They emailed me back and forth. We have a department cell phone, so we do text back and forth with patients in regards to making sure that our plan to meet is there. And of course, then we have a way to reach one another. This leads into, for this person, practicing some social connection tools using their cell phone, using email. As we mentioned, they were self-employed out of their home. So this was a big tool that they would use as well. And then also having that support that they were comfortable with. So myself, whom they had a relationship with, when I attend with the patient, I'm also doing that warm handover. So we're meeting with the other group facilitators and sharing that therapeutic relationship that's been established, sharing that link so that the patient will, if the choice is positive, will continue to attend on their own. Health behavior integration into routine. This person, as you heard, was a chronic smoker. I don't know if we mentioned that, but I think we're up to like just chain smoker is how they labeled themselves. They do have a wish to decrease and potentially quit smoking. And so one of the things that they were able to obviously commit to is when they are involved in a structured program, they're not smoking. And so to ensure that they have an outing every single day, involved in other sort of physical health and mental health benefits, they're also reducing their smoking. And so that was a really big, important goal throughout. And so this person has a 5-day-a-week out of the house for a period of time. And of course, with that emotional regulation, practicing, we reviewed things like mindfulness, how that works. This person tends to be able to practice a number of ways of being mindful through their exercise programs throughout their day. So power chair soccer. Oh, that's this one. We'll get to power chair soccer. Community follow-up and adjustment. To let you know, the first time that the client went out in the community was actually a physiotherapy program that they participated in. And they did initially report that, of course, when they got home, they were quite fatigued. But that was really important for them to learn to do some rest breaks pre and post to prepare for the next time. And that practice continued as we added different community programs to that. Certainly they noticed at the beginning of their discharge back home, increased cigarette cravings during idle time. So when they were in programs, if it was a passive participation, they definitely found that cravings went up. And so there was some different practices that they needed to put in place to help with that. And the structured accountability really helped. Now we can talk about my favorite power chair soccer. These folks are famous. This is Saskatchewan Rolling Thunder. They are going to participate in their second provincial cup in Regina at the end of March. And this is our second year in this province. So very cool opportunities. And just to show you different things out in the community, getting back to playing pool, even if they're at a wheelchair level, we just need to give opportunity to practice and see that things are still possible.
So in the beginning, we shared a quote from the patient that pretty much if they cannot continue to do things that they did, they no longer want to be able to do stuff. And they recently shared a quote with us They said, if you have definitely helped. Regardless of what I said, I was depressed to begin with. In my words, fine, effed up, insecure, neurotic, and emotional. Thanks for your patience with me. So this quote matters clinically because it shows something we can't capture in assessment scores. It's that insight, that emotional processing, and language for internal state. Early in recovery, this patient avoided emotional labeling. As they stated, like in the beginning, they refused to be able to like, I'm fine, right? But by outpatient follow-up, they could articulate their distress, they could tolerate it, and they can also remain engaged in participation. And that's emotional regulation, and it's super protective for that individual. More pictures. There we go. Oh, no, buttons. Sorry, guys. Why can I? What won't it let me? We're just gonna keep looking at. Oh, wait. Oh, this is embarrassing. I'm a recreation therapist. I'm not a tech savvy person, apparently. Why will it not? Sorry. Oh, there we go. Okay.
So outcomes that matter to the system, the participation outcomes, this is sustained independent living, increased community mobility, re-engagement in meaningful roles, improved chronic disease management integration, the system impact, improved medical adherence, reduced disengagement risk, reduced isolation, reduced preventable readmission risk. The patient does continue to work with outpatients, and we are continuing on the community transition, which leads to less appointments with me. So there's less integration. There's less direct intervention. And now what I do is follow up. The client is attending independently, and once a month is reporting in with, what program they're doing. There is a calendar that is shared with our whole Ross team because they still see OT and PT individually for treatment sessions. And so all of those things that the client is attending, that is their therapy. And as Ross decreases, they will have a lifestyle and a life plan out in the community.
So I know that we've got to wrap it up here. We can keep honestly talking forever. So to be able to close and our main takeaways. So recreation therapy ensured that this patient did not just leave the hospital. He re-entered community life with structure, confidence, and sustainable self-management. So some big things to kind of take from this, that participation level assessment identifies that reintegration risk, which can be missed by other screenings. Emotional regulation and health behavior change strengthened through meaningful activity. Like, it's meaningful for a reason. And that seamless transition requires active bridging and not just passive referral as well. That ability for us to be able to have those conversations prior to the patient discharge and to do that warm crossover. These outcomes protect both the patient, but also the system as well overall too, because I know the system's very concerned about bed flow, and to be able to have that positive and very patient-centered ability to do things and stuff is very important. Wanted to leave everybody with this quote. This is one of Shailene's favorite quotes that she shared with me, and then I created this poster, which is now in our office. My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style, written by the wonderful Maya Angelou, which we feel very much encompasses what recreation therapy is. Our contacts, if anybody wants to listen to us blabber on further, but yes, that is us. Thank you very much.
Thank you, everyone.
So good. So good. Thank you
Thank
for
you.
sharing. Boy, I'm not just saying this. I had no idea about what you guys are doing, and I'm assuming some others on the call didn't
Or
either.
the skiing.
Or the
The
skiing.
skiing is, I was like, whoa.
Vaccine seems dangerous. There is one question that we'll just put out there. For someone who is high priority for outpatient rec therapy, how long does it typically take for them to be seen? after discharge from inpatient, and that's from a Saskatoon rehab OT.
So for a priority one, who that would be typically somebody who is struggling with psychosocial risks, going out in the community. Sometimes I see them virtually, slash over the phone. I can see them within a week that they discharge. And so those are arrangements that we typically make in-house. So when that person is going, so they may not receive other services yet, but at the moment we don't have a social worker part of our team. I believe that position has been posted, so we hope to have a 0.5. But right now, that psychosocial support is myself. And so we will make sure that they have that at least over the phone within that first week, if that's what they need.
Okay. Thank you guys so much. Like, one of the big things in stroke best practice recommendations is the importance of smooth transitions. And it sounds like you guys are just filling a huge role in Saskatoon, at least for our patients. But when Ashley was doing the survey, it looked like quite a few people have rec therapy.
Yeah.
So, I mean, we need more. We used to have them in acute care at RUH, but they've taken them away from us. But they
That was
made
a
a
big loss.
huge difference. It was a huge loss.
And I want to speak to that as well too, because when there was rec therapy at RUH, that also was an added part of that continuum of care, because we received referrals a lot quicker for individuals, or also they would discuss with us prior to a patient coming over, or there were certain things that they would have assessed of that individual that we typically would not get right away when we were here. So we were able to support those individuals quicker, and to be able to have them go from those three different spaces was something that was phenomenal, and it was a massive loss to lose those positions.
Hey, so
Okay.
a project for advocating.
Yeah.
Okay, now we have to move on.
I do have a question, but I'll put it in the chat later.
Okay. So let's move on to our heart and stroke guests, Effie and Carolyn. And I'm just gonna blast through the intros. Effie is the provincial missions specialist for heart and stroke in Saskatchewan. She holds a master's in public health and, in her current role, is dedicated to improving population health outcomes in the province through advocacy, engagement, and education. Effie collaborates with community organizations, healthcare partners, and people with lived experience across Saskatchewan to advocate for system-level changes in stroke recovery and enhance public awareness through the Fast Science of Stroke campaign. Carolyn is the Director of Health Policy and Systems for Heart and Stroke in Saskatchewan. She is a registered nurse and has her Master's of Public Health. Prior to joining Heart and Stroke, she spent a decade working for the federal government and supporting communicable disease control in Saskatchewan First Nations community. She also has previous experience in research, teaching, and acute care in RUH 5300. She loves her current role and the opportunity to meet people across the province, drive health systems change, and engage directly with government. Yes, she really does find that fun. Carolyn lives in Regina and spends most of her time chasing after her 3 kids when not at work. I will hand it over to you guys for like 15-ish minutes. We can always bring you back. So if we miss anything, you will be return guests.
You bet. Thanks, Ruth. I think Effie's going to bring up our presentation here. We are so thrilled to have the opportunity to present at Coffee and Cases. It's been such a highlight of our month, being able to join in and just hear about the great programming and initiatives going on across Saskatchewan. My goal now for 2026 is to update my bio to be a bit more exciting after following Crystal and Shailene here and hearing all the amazing things that they do. I need to do more than just work and chasing after kids. But as Ruth mentioned, this is so timely because February is Heart Month. And so I'm trying to be on brand here for Heart and Stroke and Valentine's Day and Heart Month with my heart sweater that I'm sweating in right now. But we just are happy to have the opportunity to share a little bit about who we are at Heart and Stroke and specifically what we are working on in the stroke space in Saskatchewan. So go ahead, Effie. I'm going to fly through the first half of this presentation and then turn it over to Effie for the rest of it. So if you want to, yeah, we've done our intro. We can move ahead here. Boring slide, lots of content here about what we're going to cover. So just go ahead, Effie. The first slide here, first section, we just wanted to provide a little bit of a background about heart and stroke, and hopefully none of this is new to those of you on the call here. But just as a reminder, we are now a national organization. We've got presence here in Saskatchewan and across the country. We fund research, we do a lot of advocacy, and the stats on the side there just demonstrate why the work that we do is so important, both in terms of focusing on heart disease and stroke. We just know that there's so many people across Canada and here in Saskatchewan that are directly impacted. So the next slide show a little bit about how we now go about working towards our vision and mission at Heart and Stroke. Before my time, we used to be a little bit more involved in direct program delivery in each province. And for a few reasons, we've kind of revised our strategy, and we're really focused on these population level levers for driving impact. So we're trying to invest the resources that we have, including the positions we have. You know, Saskatchewan, it's just me and Effie here, and really focusing on those pieces where we can make the most impact for the most people. And we know that there's very little that we can do alone. So we're so grateful for the great partnerships and that opportunity to collaborate with so many champions across the province. I find that there's so many great things happening, you know, even as an example from the previous presentation, like the Ross program, Saskatoon City Hospital, we have that opportunity to, you know, come alongside, learn a little bit more about local initiatives like that are working well, and then help with that advocacy to see if we can expand that to become more accessible province-wide. So we love doing that and love just working together to figure out how we can add value to the work that you're already doing. The last kind of background slide we have here is just a little bit about some of the work that we are doing specifically here in Saskatchewan. So Effie and I, you know, we're working on 5 main priorities. 2 of them relate to stroke, our Fast Signs of Stroke campaign and stroke rehabilitation that we'll touch on briefly. But we're also doing work around cardiac arrest, smoking and vaping, as well as heart failure. So really trying to look at bringing care closer to home and creating healthier and safer communities across the province. So getting into a little bit more of the stroke information here, I'll just touch on some of our stroke priorities, and then I'll turn it over to Effie to talk about some of the resources available and how you can get involved and support the work that we're doing. Ruth has, you know, touched on a little bit or mentioned stroke best practice guidelines, and hopefully that's not new to anyone on the call here. But Heart and Stroke is the lead on these guidelines, these national guidelines that inform stroke care across Canada. And we are so well represented from Saskatchewan in developing these guidelines, and are just so grateful to the many experts who have lent their time and their wisdom to help support these. So there have been a number of updates completed last year, and a number that are, I know, currently in development, and I may be even missing a few on this slide. One of the ones that we have been anxiously awaiting was around the rehabilitation and recovery module. And so that was just recently released at the end of 2025, and we're really excited to kind of hit the ground running and take that and use that to spark some conversations in the stroke rehab space. The next slide talks about a webinar that's coming up. March 11th, mark your calendars. There's a QR code there that you can scan. And I should mention, this presentation is going to be a whirlwind. We're going to try to condense it to 15 minutes or less here, but we will follow up with a lot of the links to some of the different resources that we're sharing about during the presentation. So this webinar, it's going to be short and sweet. It'll just be an hour, and it will be recorded to send out afterwards if you're not able to make it. But it'll provide an overview of the updates to the rehabilitation and recovery module in stroke best practices. But I'll just note that we've had some recent conversations with the team at Wascana Rehab and City Hospital to see if there's any other education opportunities that we can provide for those working in that rehabilitation space across the province. So stay tuned, because there may be more coming your way. The next section that we'll share about is Fast Signs of Stroke. We have our campaign going across Saskatchewan. We're really focused on trying to target rural and remote areas. So you may not be seeing quite as much messaging in terms of TV and radio and billboards in Saskatoon and Regina and some of those bigger urban areas. But hopefully, as you travel outside of those cities, you'll see a little bit more of those messages. And we know that just with response time with EMS, it's even more important for people outside of those major centers to know the signs of stroke and know to call 911 right away. So we're so grateful for all the in-kind partnerships, both with our media vendors that we have who go above and beyond with helping to share our messaging, as well as all of you. Effie has some screenshots here from our toolkit. So we do encourage everyone, if you can think of a channel where you can share fast signs of stroke, whether it's putting up a poster or sharing on social media. We've got some fabulous videos that feature our very own Ruth Whalen that are wonderful, and we can share those as well. And so any way that you're able to support getting that message out there, we know that it really makes a difference, and it's so important for people to know what those signs of stroke are. And finally, the last section I'll cover here before passing it over to Effie is just a little bit more about stroke rehabilitation. So I just have one slide here, basically just saying we are excited to dive a little bit deeper into this space. We've been waiting for the release of those updated guidelines. And now that that's in our hands, we just can't wait to start some more conversations about how to strengthen stroke rehabilitation across Saskatchewan. And just for your awareness, I know before my time, there was a lot more focus from Heart and Stroke on acute stroke care. And I know there was a lot of support to Ruth and Dr. Mike Kelly and others to implement that acute stroke pathway. Now we're seeing such great, the impacts of that, right? Where people are surviving stroke, and it's great. They're receiving that timely access to treatment, and actually it's improved survival rates. But then we have more people living with stroke. So that's why we're shifting our focus now to the rehabilitation space. And what that looks like is still a little bit to be determined. We hope to support some education, some capacity building across the province, and also look at our advocacy role and how we can maybe add some value of directly advocating to government for the investments and resources that we know are so needed in this space. And with that, that's all from me. I will pass it over to Effie to wrap up the presentation by talking about some of the supports and resources that we have.
Yes, thanks, Carolyn. So the first piece that we'd like to talk about is the health information publications that are available directly through Heart and Stroke. So of course, our goal is to inform, educate, and raise awareness, and we want to make sure that we have resources available for patients that they can access at any phase during their stroke recovery journey, and as well as resources for health professionals as well. So we have various resources on quite a few different topics. In the stroke realm, we have stroke recovery, so anything from pediatric stroke to stroke in young adults to our Living with Stroke booklet. We have our emergency signs, the fast signs of stroke materials, bookmarks, posters, checklists. And then on the prevention side of things too, we have risk factors, blood pressures, cholesterol, talking to doctors. So a variety of different handouts and guidelines that both patients and healthcare professionals can access. You may have already have some of these in your clinic, but if you don't, these are all available as printable PDFs, and some are also available in ready to order print versions. So all you need to do is fill out an order form, and then you can expect your printed copies to arrive within about 5 to 14 business days. This form will be included in the post-meeting email as well. So if you are looking to get any health information publications from Heart and Stroke, that is how you receive them. On a Saskatchewan specific level, we've recently developed a bit of a stroke recovery resource, thanks to many of you who contributed resources that are available in your area. What it is, essentially, it's a PDF, it's a digital resource currently that outlines over 100 available supports for stroke survivors and their families to access in Saskatchewan. Different topics that are covered include anything from aphasia to employment to home care, palliative care, rehab, transportation, and they outline many different resources available across the province, whether they're virtual or in different areas of the province. They outline different resources that both patients and families can access. So currently it exists as a PDF. Please feel free to share this resource if you go through it and think it's something that could be beneficial for your patients or other healthcare providers that you work with. Feel free to share it around. We will distribute it following this call. It is updated as needed. So if you see that there's any gaps or you have some really great programs in your areas that aren't listed here, please reach out to me. And then also, if you'd like to be on our update list and make sure you always have the most up-to-date version of it, just send me an email and I'll make sure that you are on our list. One of the great resources listed in that Saskatchewan resource, and also a bit of a plug for one of our new heart and stroke tools, is Heart and Stroke's Risk Screen. So it's an online tool that's developed to help Canadians understand their individual and unique risk factors and how they can take action to prevent or manage their risks. So what it is, it's an online quiz. It takes about 5 minutes to complete. It asks a series of questions about your modifiable and non-modifiable risk factors. Once completed, it'll make you a customized risk profile, and it'll tell you how you can work to reduce or manage your risks to live your healthiest life. Now, today we were also asked to specifically speak to smoking cessation resources available in Saskatchewan. These are also outlined in that Saskatchewan Stroke resource booklet that we've developed, but I do want to share some of the great resources that we have available for patients in Saskatchewan. One of the best ones, I think, I'm impartial to it, but Saskatchewan Quits is a supportive Facebook group. It's for anyone looking to quit or cut back on smoking throughout the year. It has about 1,000 members. It's very active. It's completely free and open to anyone in Saskatchewan to join. They constantly share multiple times a week tips on quitting smoking, different lung health tips, wellness, and inspiring stories from others. So the best part of it is that it's a great peer resource. You get that peer support, and you also get professional support from all the members, such as Lung Saskatchewan, Heart and Stroke, Smokers Helpline, Pharmacy Association of Saskatchewan, and also from November to February of each year, they host a special challenge. There's a chance for members to win prizes, as well as free NRTs, which we know is often a barrier for people to quit smoking, are given to all participants as well. But it is active year-round for that continual peer support, and many people have been able to quit through the use of this group. Another great resource available is through Lung Saskatchewan. They host the Quit Smoking resource page. It's maintained by the Saskatchewan Smoking Cessation Collaborative, which Heart and Stroke is a part of, as well as Canadian Cancer Society, many other organizations. We regularly update this information and help support residents in quitting tobacco and vaping by making sure that this is a one-stop shop for all resources available across the province. It's quite interactive. You can filter it by location, audience, cost. If you're looking for NRTs, depending on what you need, we have resources that outline how to get free NRTs, different helplines you can call, education, and more. So that's another great resource to recommend to your patients if they are looking for cessation support. And finally, if you yourself are looking for a better way to support your patients, just wanted to throw out there that the Pharmacy Association of Saskatchewan has developed the PACT program, which is the Partnership to Assist in the Cessation of Tobacco. It's designed to build capacity for healthcare professionals. It's a $99 course. It takes about 8 hours to complete, and it outlines tobacco use, the psychology of addiction, the benefits of quitting, motivational interviewing so that you can be more aware of how to best help your patients through motivational change. There's also an Indigenous tobacco cessation module. So if you are looking for any more education yourself and how you can better help your patients on their quit smoking journey, this is a great resource to check out for yourself as well. Last topic here, we just have some different ways that you and your patients can get involved in the work that Heart and Stroke does. So first, I'd just like to talk about a bit of our volunteer work that our amazing volunteers at Heart and Stroke do, which many of you are already involved in. We have volunteer opportunities for people with lived experience of heart disease and stroke, their caregivers, their family members, as well as healthcare professionals. When our volunteers share their stories with us, it not only contributes to their overall recovery, but it connects individuals from across the province and beyond who have all shared those same similar experiences. And it really helps us create change and contribute to improvements to the healthcare system as a whole. And we are always looking for new volunteer partners for our Heart and Stroke team. and both patients and medical experts. So you might recognize here, we have Ruth Whalen, we have Dr. Shi, and many others who have donated their time and resources to volunteer with us. So what volunteering could look like, it could be media interviews, could be supporting advocacy initiatives through meetings with government, could be speaking at events, participating in advisory committees, contributing to research, and so much more. We always have a variety of opportunities. For instance, right now we're seeking volunteers with a rural and farming background to share their stroke experience with us. So if you know anyone who might fit that bill, please let us know. This was a specific request that came to us from the Canadian Centre for Rural and Agricultural Health. They share out a newsletter twice a year to farming families on health, and we'd love to share in the June edition a rural PWLE who has had a stroke and their recovery journey. And one more topic we'd like to cover before we wrap up here. June, of course, is Stroke Month. I know we're still in Heart Month, but it's never too early to start thinking about it and how great of an opportunity it is to increase awareness about stroke symptoms and risk factors, recognize the amazing work that all of you do every day, and celebrate advances in stroke care and treatment. And here's some amazing photos of our stroke months throughout the years. And I know it's approaching quickly. We encourage everyone to share those FAST materials that we shared earlier. But if you have any new ideas, the Heart and Stroke team, aka me and Carolyn, are always happy to support any events that you have planned or would like to do in the province coming up here. And thank you for listening. I think we're just under the wire for time. But if you do have any questions, you can always email us or maybe we can answer some quickly. But thank you everyone for listening.
Oh man, I'm so sorry that you guys had to rush through that because there was so much good stuff that just blasted through. Okay, I think we're
You
definitely
can expect
gonna...
a follow-up, I think from Ashley with a list of a whole bunch of resources
Yeah.
and links that
Yes.
we touched on.
And I mean, it's a great time to start thinking about June, it being Stroke Month. And we're gonna ask if you guys want a bit of a package for how you could support or do a like Wear It Wednesday or a stroke celebration or stroke awareness campaign in your sites during June. It'd be pretty cool if the whole province could figure out, hey, what day are we gonna do it? And then have a bit of a plan. I think that would be cool.
There's empty.
I'm not looking at what anyone else is thinking, but I'm sure you're all giving big thumbs up. Okay, we have one more thing we want to do. And it is, what did we call it? No, the
Oh, rewire and inspire.
Rewire and Inspire. So this is kind of a new feature in Coffee and Cases where we want to celebrate what everyone is doing. And I'm sorry to say there was no submissions this month, which is really sad because, I mean, we do great work. So please, please, please tell us what you're doing well. But there was no submissions.
It's anonymous.
It's not. Well,
So just brag about yourself. We want to hear
Yeah.
all the things you're proud of.
Brag about your friends. Brag about whatever.
Yeah.
But I mean, of course, we couldn't let it go. So, oh man, just a second. I am gonna share something here because, and I created I created something to maybe motivate us to celebrate. And so just one sec, it's coming. Okay, so I think you guys can see this. I created the Golden Lobe Award. And it is for it can go to anyone who did something great this month. So in Rewire and Inspire, tell your friends you could get the Golden Lobe Award. So this month, I went through some TNK times. Last month, Melfort really did such a great job in one of their transfers, and we talked about it, and I didn't have the Golden Lobe created, but last month was Melfort. This month, we're going to give it to Lloydminster, and here's the reasons why. Number one, who thought a border town was a good idea? Like, right there, they deserve the Golden Lobe. Number two, navigating Alberta Health Authority and Saskatchewan Health Authority mishmash is a real nightmare. And we love you guys for providing great care, regardless of if patients are in Alberta and Saskatchewan. And number 3, what? Last month, they gave TNK twice from January to today, and their door to needle median time was 37.5 minutes. So way to go, Lloyd. That is why you deserve the Golden Lobe Award. And please don't forget to submit why you guys deserve it and why you are awesome. Okay, thank you to our presenters. Thank you, respiratory therapy, rec therapy, Crystal and Shailene for just sharing your amazing presentation. And thank you to Carolyn and Effie for telling us all about what Heart and Stroke is doing in the province. And happy Valentine's Day. And we will see you in a month.
Thank you. Bye.
Bye.
Bye.